The narcotic guidelines are important because what it's doing is trying to standardize what happens in the emergency department and when it comes to narcotic medications that are prescribed to patients. Last year, in about September of 2011, the American College of Emergency Physicians, as well as a number of other groups, worked to adopt guidelines about what will and will not be prescribed out of the emergency department. Some of the highlights of those programs are that we will not be prescribing chronic pain medications out of the emergency department. Refills will not occur. We will not be replacing lost or misplaced medications. Methadone is not a treatment option out of the ER, nor will we be refilling missed medications for any reasons as it relates to methadone. Chronic and long-acting narcotics such as fentanyl, OxyContin, MS-Contin will not be prescribed generally out of the emergency department for any reason. Additionally, with those that are on chronic pain medication, we will work to refer them back to their primary care providers. We will work to only use oral narcotics if and when it's deemed appropriate rather than IV narcotics, since that is not something they have available to them at home. Additionally, some groups have taken this a little bit further and have gone to what's often referred to as the oxy-free policy, meaning that we will not be prescribing oxycodone or Percocet out of the emergency department for anything other than acute objective severe pain. Kidney stones, broken bones, the like, but that if it's chronic abdominal pain, a flare of your low back pain, dental pain, Percocet and oxycodone are not going to be part of the solution. Motrin, Tylenol, codeine, possibly Vicodin will be part of the solution as the individual physician deems appropriate. And I can tell you from personal experience, it's been successful where I work at St. Joseph's Medical Center in altering our conversations about our prescriptions. We want all physicians to be aware of the guidelines so that if patients are calling the office saying they're out of their chronic pain medications early, or that they're having worse pain from an acute injury such as a broken bone, and they're seeing an orthopedist, referral to the emergency department for additional pain medications is not the appropriate step, but that we need to get those folks back into the primary care office, back into the consultant's office, call in a prescription, or come up with another solution other than sending to the ER, because the ER will not be replacing chronic pain medications. We want to integrate the care, and we want to make sure we're getting people to the right place, and medication refills is not in the ER. Well, the prescription monitoring program is an idea that has come out of other states. About 20 to 30 other states have a prescription monitoring database. And what it does is it integrates with the pharmacies and pulls together the information about narcotics and other controlled substances that patients are having filled. And that data is centralized, and so when you log into it, you say, I want Mrs. Smith's prescription records, and it prints out what they've been filled and where they've been filled and who's been prescribing them. The system is managed by the state through the Department of Health, so you have to register with them and certify your computer. It's a little bit cumbersome, as I've mentioned, but once you get the hang of it, it's very useful. You can also assign delegates to do it for you and get that information. And it'll allow you to verify for your chronic pain patients that they're not seeking medications from elsewhere. For those that you're managing through an acute episode, that they're only getting their medications from you, and to see if they're filling them on time or early, or other variables that you may be concerned about in terms of their prescription habit. Well, so we're required by the alternative plan to have 75% of emergency physicians, but we really want to get everybody involved in the program. We feel that this program is only going to be successful if primary care is utilizing the system as well as those that manage chronic and ongoing pain, and aggressively have conversations with their patients about, hey, why did you get a prescription for narcotics from the emergency department last week when you're only supposed to be getting meds from me, and you never called the office, and you didn't tell the ER that you were on a pain contract, and you filled the script anyways? This is a red flag that we're going to have to reconsider your pain management issues here in the office. It's going to be a tough conversation again, but it's a critical one to have, and you're never going to know it potentially if you're not involved in the PMP program. So it's critically important that everybody's involved, and it really will help you, I think, give better care to these patients and help coordinate with the emergency department and get them to start to hopefully honestly state to the emergency provider what medications they're on, since they know that you're watching as well as us.